am trying to join through laptop. I cannot hear you people.
हाँ
बहुत
मैं
कम
भी
आवाज
एक्चुअली
आ रही है.
लैपटॉप से करती हूँ. I will rejoin.
Better. Good afternoon, Sai sir.
Good afternoon.
Yes, yes, sir. And thank you for this afternoon, Sunday afternoon, for joining. It's a little bit difficult time actually, post lunch Sunday, and we are just taking your time, important time. So it's already 3. Tapan, we can start. You just
Yeah, you can start. I've already started doing recording work.
okay. So very good afternoon, everybody, and thank you being here on this difficult time, 3 to 4 p.m. post lunch Sunday. Thank you all, and thank you UPAP. It's continuation with our history examination, basic of the heart failure. Now this is chest exercise. Very basic, low-cost investigation says a lot. So lots of information we get from this thing. So speaker with us is Dr. Subhi, the chairperson, Dr. Smita Mishra and Dr. Vinny Saxena. I request Dr. Smita Mishra to take over and introduce Dr. Sudeep, and then we go ahead with the presentation. Dr. Smita.
क्या किया?
Dr. Smita?
हाँ? अरे फिर 2 मिनट पहले हुई है, तब से मैं पसीने पसीने हो गया. अभी अभी 2 मिनट जब तू अंदर घुसा तब चालू हुआ है. चल तो ना रहा है वो. तुमने लापरवाही से अपने काम करा के. नहीं 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 नहीं.
Please mute yourself. Dr. Smita, are you there?
Yes, I am there. Dr. Sudeep Verma is pediatric cardiologist in KIMS Hospital in Secunderabad. He is a very hardworking person and he has done something remarkable by collecting all the X-rays, and they are very useful in the cardiac for the at least at the secondary care level, which is not a through and through cardiac setup, cardiac surgical setup, where you know everything and echo is handy. But most of the time in bedside, when you are having even echo which is suboptimal, then your X-ray actually plays a very interesting role. Recently, I got a patient who has a mitral, who was operated for mitral regurgitation at the age of 1 year. Now at 13 years, there was a lot of confusion that the second surgery is needed or not, when mitral valve gradient, mean gradient was around 14 and it was increasing. Somebody in meanwhile said that there is a associated pulmonary arterial stenosis. Yes, pulmonary arterial size was borderline. So in this particular case, in this cath was done, and still the mean PA pressure were actually minimally high. So when I saw at the X-ray, after such a long time, I never went for the X-ray just for this child. And when I saw, and I was so clear in my mind that this child should be operated. So X-ray is very important for all of us as a cardiologist, as a pediatrician. And I welcome Dr. Sudeep Verma, and please enlighten us with your knowledge and whatever you have learned during your book writing. The book was written by Dr. Sudeep and Dr. Neeraj.
Thank you, ma'am. So thanks a lot, Munish madam and everyone, to give me opportunity to talk with UP and thanks IIP also. See, this is what my experience over the period, even the basic always remains basic. However, we advance X-ray, ECG, clinical examination, saturation, they are the important part. So the first slide itself shows this was the patient referred to us 4 years old with some pneumonia they told, and then they referred to they found out that there is a X-ray, but you can see there is clearly there's a shadow seen like a sword. They turned out to be the scimitar after CT scan. But the X-ray itself is very clear. Right side lung is small and the scimitar sword pattern. So we'll go with this. This is our book. So this is the one which which mesmerized me. This is the one X-ray with the some hyperdynamic circulation of 5 year old, and they just first went to the nearby. They thought they do X-ray, and they found out this is pass on. The radiologist pass it on as normal, but if you see the stomach is on the right side, and there is a prominent RPLP which they missed. The stomach is right side, so then it's turned out to be the left heterotaxy with a moderate ASD. So just with this stomach shadow on the right side, you can see there is no stomach shadow on the left side. We have to think with our clinical knowledge and with the plethora little bit seen, you have to suspect whether you come out with some diagnosis or not, but if you ruled out, that itself is a big thing. So sometimes the small clues can give a good inspection about the heart. So this is one of the very famous, I always show, identify the problem. It's written like India's leading diagnosis, they are reading X-ray opposite. So you can see even the smallest, they're not able to, the basic, they're not able to do, and they're advertising like that. So that's not the problem. Ignorance is a bliss until you hit the ground. And this is a very famous quote, the eyes don't see what the mind is now. So with the X-ray particularly, it includes in a major, not major criteria because it depends on so many technical factors. That's why with the abnormal X-ray, ECG, BP, and abnormal secondary concept of the minor criteria, while CCF, cyanosis, diastolic volume, systolic volume considered to be the major NADA's criteria in diagnosing the congenital heart disease. So this is simple, I won't go, but just we should know the volume overloading conditions, pressure overloading, inflow as well as outflow obstruction, as well as the cyanotic increase or decrease flow. So in general, wherever increase flow, the X-ray, some features are always same. Wherever decrease flow, some features are always same. And when there is obstruction on the left side, some features are always common with any all those things. So that we'll discuss now. So whenever some first thing is the clinical status of the patient is very important. Without clinical status or without clinical history is imperative. It's not correct to comment upon anything. So first with that X-ray, if you just add cyanotic or acyanotic saturation, your things become much easier. Whether pulmonary flow increase or decrease, you see the general intercostal retraction or the tachypnea, nasal flaring, you know it's a plethora increased flow situation rather than decreased flow situation. But then the third thing will come with any congenital heart disease, whether it involves X-ray, ECG, echo. There's a originate in the left or right side of the heart, and which is the dominant ventricle, whether pulmonary hypertension, either arterial or venous is present or not. So this in general, how cyanosis, shock, and CCA present in the initial ways of presentation. Cyanosis, TAP with it, some truncus, tricuspid, TJ, they present from the birth, while shock present with the mostly left side obstructive condition. And when the PVRI drops in 1 to 2 or 4 weeks, all the left to right shunt appear, which is got significant. It appears significantly before in the preterm because they are less of smooth muscle, the remodeling won't happen. So directly there will be increased flow from the beginning. That's why all preterm, the same shunt which present later in a term may present earlier in the preterm because lack of smooth muscle. And the second phase of smooth muscle remodeling of PVRI won't be there in the preterm. Maybe. So this is so. Apart from that, if somebody sometimes other things will know, but sometimes if some X-ray given to you or we don't know what is the status, you should still get some clue whether it's a pre-operative X-ray or post-operative X-ray. So this is the first clip, second wire, bone deformity, sternal wire, and the vascular clips or the contrast in the seen in the kidney with the device. So that will show either some intervention or done or some surgery was done. So and what are the different approaches? Just to enlighten, this is the one X-ray where the patient was extubated but got severe distress. And when we sent for the X-ray, we found out, once you know, this is known as the perimeter approach, which you know, that means you have to, because every time when we are seeing the X-ray, we concentrate in the center, we're not seeing the periphery. Once you see the perimeter approach of the thorax, we come to the ICDs out. So this turned out to be the ICD, which by adventure not in the lung, and that's why when the baby got extubated, got of the suck the air from the atmosphere and cause the pneumothorax and distress. So there's a simple thing with that will come to know that this is just the pneumomediastinum because of the ICD. It is out. Apart from that, these are the work perimeter I told. You can see the curvature of the heart, the chest on the left side as well as on right side. Right side, the rib deformity is there, and some vascular clips are seen. That means this is some thoracotomy surgery was done on the right side that causes the rib deformity. These are the simple clues. Then, like an inching method of the auscultation, you have to go from one, take any one point and just go everything and then try to see what are the different for findings you are finding, then you will not able to miss. And the last, this is like first, we'll do the abdominal situs first, second, then the cardiac situs, and then we'll go from outside to inside to determine the what are the findings. These are the various approach, zigzag approach or perimeter approach, and then the usual approach from the situs like that we are seeing in the cardiac patient. Last, if you see, if you go from the situs and then go here, the situs is on the left, right, liver is on right, stomach on the left, but the heart is on the right side. So that means there is a situs with the cardiac discordance is there. So when such things are there, the more common problem of the complex congenital heart disease will be seen. Last approach, we can see the quadrant approach. Like ECG, we are doing 4 quadrant. We can do the 4, and then we can divide all, and then we can try to see what are the findings present in each of the quadrants. So once we do that,
Hi, Dr. Sudeep. Just want to tell you that you are going little fast because audience is asking you be little slow. It's a wonderful presentation and they want to concentrate more.
okay, I'll go slowly. So these are the quadrant. So any X-ray divide 4 quadrant so that you can come to know what are the findings and then you're able to concentrate better on that quadrant and that finding. So this, for example, and there are some hidden areas like above the clavicle, below the heart. These are some hidden areas where we have to concentrate. Apart from seeing that, then we're able to make the complete description of the X-ray. So this one you can see this patient come to us with a small VS which is not explaining the distress, and you can see there is a hyperinflated right upper lobe. It turn out to be the azygous lobe or some hyperinflated bulla on the right upper lobe. So once we just start seeing that, why it is there, we have to see the hidden area. So in the same way, this patient come with a dilated cardiomyopathy, but there is
Dr.
another.
Sudeep, excuse me, you just please from the pointer you show that area which you think is a azygos lobe.
Oh, just a minute. Just a minute.
Hmm. I think computer pointer you can use.
Yes, I'm using.
Hmm.
Just a minute.
Please mute yourself, Siddharth Sankar iPhone. Please mute yourself.
Just a minute.
Hmm.
Just a minute. Stuck actually. Sorry.
Okay, if it is not happening, it's okay.
No, sorry. I'm stuck actually.
Okay. Hmm.
Just a minute. Excuse me. Just one.
So any question till now, any audience, if you want to ask any question?
You all can put your queries because this is the best time, whatever your mind, just better.
How many of you think that superior mediastinum is broader?
Stuck. Okay, ma'am. Shall I proceed? Sorry for that interruption.
Right.
Yeah.
Okay. So if you see the arrow, I pointed out the orange arrow. This child turned out to be, he swallowed the needle. So he's having some gastritic symptoms completely. So even with that, once you see the heart, apart from heart also, there was needle in the stomach. So like that, you have to think beyond heart also nearby structures you have to think. Second thing, how to take the cardio. This is very common question. How to do a CT ratio. So this is the one thing which so many students I'm asking, they are unable to. So first you take the vertical line from the center and do the maximum excursion on the both margin of the heart. You can see here the dotted line and then the maximum transverse thoracic diameter. So the general concept is there are three different criteria: 0.5, 0.55, 0.6. So because the neonate already there is a more expiratory, they're not able to hold, and the neonatal volume is more. That's why the criteria set for the neonate is around 0.6. For the infant also or smaller kids also 0.6. Once you go the chill childhood age, then it's a 0.55. And once in the adult age, it's a 0.5. So the different criteria for increased CT ratio in neonatal, adolescent, as well as in the adults is 0.6, 0.55, and the 50. And the second thing, just take your hand. This is a bedside method and describe authentically. You just check like this what I made, how is the heart and how much is coming beyond that. So first take the heart from your finger to the thumb and then take how much is. So if you see the heart, it's covering almost more than 55 to 60% of the hemithorax. So that means there is a cardiomegaly is there. So this is the way to do the bedside also. No need to take scale, just take with the hand and then do it. So this is the in general method for that. So now the third and most common, if somebody asks what is the most important information you will get from the exercise, one is vascularity. So for that you should know there are what is the normal vascularity, what is the increase, what is the pulmonary venous hypertension. So if you see, these are the various zones we divide from the second rib, from the mid clavicle, we divide into three zones in the vertical zone, and then we divide at the enter end of the third and sixth rib will divide into three upper, middle, and lower zone, and the inner, outer, and the middle zone. So that way you divide the heart into multiple segments, and then you can currently describe how to which segment is having problem. So this is the three important vascular pattern. We'll go individually also. Normal vascularity is a gradual tapering. You can see the first X-ray. There is only the vessels are seen with difficulty in the lateral third, but you are visible to see. Second is the plethora, which has got the more over circulation, means the more wide and prominent vessels are seen throughout the lung and below the diaphragm also and in the periphery also. Oligemia, that means there is less flow. You'll able to see some vessel in the inner one third, but you will not able to see the outer one third, and the X-ray will be more black. So this will be oligemia, plethora, as well as the normal vascularity. Apart from that, the two concepts are very important. What is equilibrium and the active congestion, and what is the redistribution and the passive congestion? Equilibrium, active congestion with the blood is going more towards the lung, like in all large left to right shunt, like all RSOV, all AVMs, where the more flow is going to the heart, more flow is going to the lung. So it will be equally distributed. If you see the second one, sorry, again, if you see the second one, the vessels are seen throughout the right lung, upper and lower, importantly. But if you see the right side, that is known as a passive distribution. Passive distribution means normally what happened, the lower limb vessels are more prominent. If you see the lower zone, if you see the first X, the lower zone vessels are more prominent because of the gravity and the pressure difference between upper and lower. So that's why the lower zone vessels are more prominent. So what happened, once there is a venous congestion on the left side, there will be spasm in the lower zone. Where there is congestion, it will causing the spasm, and that's why it will redistribute more to the upper zone. So there is a high gradient between upper and lower. So upper zone pressure is less, so it will go more towards that side. So that is known as the reverse mustache sign or antler sign. You can see the last section, upper zone vessels in the both lungs are more prominent than the lower zone. So this is known as the redistribution phenomenon. That is important on any left-sided condition. So that is known as the pulmonary venous congestion. equilibrium active congestion is known as the more flow to the lungs, so you call it as plethora. So plethora in general is the more flow to the lungs because of the increased flow, and it is found in the condition with large left to right shunt. Venous congestion, PVH, is because of the redistribution phenomena and mostly because of the left-sided heart condition, which is causing the more flow towards the lung than lower. So this is the in general what. So now this is the one you can see. One of the very important phenomena, if you see any infant with CCA, what happened when the heart failed or when the heart is functioning normal, but the more flow is there, that will cause more flow to the lungs. So that is causing some reflux, which causes more hyperinflation. So any infant, if you see the more hyperinflation with the plethora, that means it's a sign of CCF. So the reason, don't know, but there is the reason. Literature showed the hyperinflation is a sign of CCF in an infant. So if you see this X-ray, MPA is prominent, L is plethora is there. You can see both lungs are white, all vessels are seen below the diaphragm, periphery. So this is the typical of the plethora. This belongs to X-ray belongs to a large VSD causing left to right shunt. Apart from there are some other criteria where we can tell. You can see this is a right descending pulmonary artery and trachea. If normally RDPA and trachea are more or less equal size, but when the RDPA increase, it increases in two conditions. Either it will be more left to right shunt where the RDPA increase, or more pulmonary hypertension like idiopathic or Eisenmenger where the RDPA is more than trachea. So that itself is suggestive of pulmonary hypertension. This is one of the important criteria for PAH assessment in adult or in the grown-up child. See, this is like, and third, so hyperinflation. What I told you, you can see the left side X-ray 1, 2, 3, 4. So when you call hyperinflation, once your anterior rib is more than 6 space and the posterior rib is more than 9 ribs, you are saying, that means there is a hyperinflation. So if, and apart from hyperinflation, you can see there is an end-on vessels and there is a vascularity which going beyond the periphery. So what are end-on vessels? This is also a very common question. What happened when the blood flow more towards the lung? The vessels are getting tortuous, and once the X-ray take, all vessels are in the different plane. So that vessel, dilated vessels and the plethoric vessels will end on as a appear as an end-on. So whenever end-on vessels are seen, so like I'll show here, this is the end-on vessel. This is the end-on vessel, you can see. These are the end-on vessels that I marked, you can see. So these are the end-on vessels. This mostly find in the near the hilar region. Okay, so whenever end-on vessels are seen, that is suggestive of plethora. And once 3 end-on vessels on one side and the 5 end-on vessels on two sides, that is suggestive of your plethora. So this is very important concept for the end-on vessel. Yes. Okay, so this is there. Now, sorry, I have to remove that. Wait a minute, I'm sorry. Okay, and now this is one 15-year-old with RHD. You can see there's a huge heart, and the upper lobe vessels are more prominent than lower lobe vessels. You can see this is typical of the pulmonary venous hypertension. This child is having severe MR, that is causing the LA enlargement and the upper lobe vessel, that is known as cephalization or antler sign or the Mustache sign. Now, apart from this, is the first stage of the pulmonary hypertension. If you see like this, see the vessel, bronchus and the cuffing, and these are the fissure. This is known as curly line, minor fissure as well as curly lines. So what are the peribronchial cuffing? Because of the increased venous pressure, there is an edema around the peribronchus. So that peribronchial cuffing. That itself suggests your venous hypertension. That means your LA pressure is more than 15. Once you see this minor fissure, take this for granted. Whenever you see the minor fissure like that, in the right lung, minor fissure is prominent. That means definitely the fluid content of the lung is increased. Either it's not overflow, it's always because of the left-sided heart condition. So that is indirect evidence of pulmonary venous hypertension. So minor fissure prominent is an indirect sign of PVH in any X-ray. And the peribronchial cuffing, these are again the signs of pulmonary venous hypertension, that means pathology on the left side. So if you see like that, if you see the clips, that means the post-op, you have to see every time the correctness of the film, and you can see then the first thing will always come as the identification, second the clinical detail, technical aspect, okay, then approach, then we say like the situs, cardiac, zigzag, quadrant approach, and then whatever the clinical setting you have to interpret in context of everything. So now we'll go one by one how to go and how to diagnose that. So if you see acyanotic, this is the child with a acyanotic heart disease, saturation is 19%. This is the X-ray. You can see the LA is enlarged, and you can see the heart size is enlarged, and there's a end-on vessel. That means the plethora is there. That means it's an increased flow. So now the question
Hey,
comes.
excuse me, Dr. Sudeep, because we talked about the LA enlargement just to make it more interactive. So LA enlargement we see in rheumatic cases, mitral regurgitation and mitral stenosis. And we also see LA enlargement in the ventricular septal defect, large ventricular septal defect or duct. So how it differs? So please tell us in the next few X-rays.
Okay, ma'am. See, the LA enlargement uses the two things. There is a volume enlargement is there, and second thing is the pressure plus volume, maybe both. Like in rheumatic heart disease, the pressure enlargement will be there where the LA appendage is already involved. So whenever LA appendage is involved, I'll show actually, sorry, I forgot to include that. So I thought ki rheumatic I won't cover, that's what I not included that actually. So whenever the left side heart border some problem is there, I'll just, if you don't mind, can I take madam once? Okay, so that I will later explain, madam. Then the last slide I'll include 2, 3, and then I'll explain. So this is the X-ray that shows the plethora and the acyanotic heart disease. So this is the typical of a acyanotic when you see the plethora and cardiomegaly. This is the increased flow situation like you see in the VSD or ASD or the PDA. The difference between ASD, VSD, PDA comes with the hemodynamics. ASD, the RA-RV is more dilated. So how you will see RA dilatation and how you see the LV dilatation and how you see the LA dilatation. Whenever if you see the arrow, dotted arrow, the apex is going down and apex is towards the diaphragm. This is usually the LV apex. When the apex is upturned and it's the axis is towards the your chest wall, that means vertical axis of the axis, that means this is the RV apex. So here the apex, that is known as the cardiac apex axis, which is going towards the diaphragm and instead the vertically down, that means the LV apex with the plethora. The LV apex with the plethora, usually all post tricuspid shunt will come like VSD, AP window, PDA. So these are the typical of, this is the typical of the LV apex and with the plethora, and this turned out to be the large VSD. What are the end-on vessels? Again, sometimes you have to go with the nearby bronchus. So that is known as AB ratio. This is also one of the criteria. Normally, this, you can see the blue dot. This is the bronchus marking, and the white dot is the end-on vessel marking. Normally, these are equal, but whenever the plethora is there, these markings become prominent. So this is also again one of the criteria of a plethora. In AB ratio, the end-on vessels become more than the blue vessels. So that is the post-tricuspid shunt in the plethora. In the same way, you can see this X-ray I want to explain. See, this is also a large in a later date. So you can see there is a plethora, this is a total whiteout, cardiomegaly, decreased flow, and then there is a minor fissure also seen. Okay, this is my arrow is there, you can see. This is the minor fissure also seen. That means there is a pulmonary venous hypertension also there. This is a late presentation, so that whenever large VSD will present late, it will cause the LVEDP to increase. And again, there is a combination of the vascularity. So here the pulmonary minor fissure prominent in presence of plethora, that is suggestive of always PVH as well as the plethora. So this is the one case where the VSD, in presence of VSD, the both vascularity is present. Okay, so now somehow how the serial X-ray formed. This is the one patient at the age of 5 months. You can see the X-ray is at the very huge cardiomegaly prominent way, and the whiteout lungs are there. The same patient come at the age of 12 years. Now the cardiomegaly got totally reduced, and you can see the PA is very prominent here. Okay, but there is a no vascularity seen in the periphery. But here in before the vascularity used to be seen in periphery. That means it evolved from into increased flow situation to the Eisenmenger. So this is the same patient having at the age of 5 months and having the 12 years. The PA is very prominent. There is no vessel seal. So what is pruning? So pruning, the objective criteria is whenever any vessel got more than 50% reduction in the next cycle or in the next generation, that is known as the pruning. Here, that's why the in the proximally you can see there are large vessels, but in the periphery you will not see anything. So that is typical of the pruning, and which is seen when the Eisenmenger physiology is there. So how the serial X-ray help is also tell, and they came for the surgery. So if I ask whether we'll do surgery, no, because there's no cardiomegaly, and when we check the saturation is 88%. So all suggest with this serial X-ray there should not be operation possible. Then you have to do the only to work in the future for the heart lung transplant. So in the same way, how the enlargement will be seen in the RA. This is the one X-ray you can see in the large. This is normally what happened if you see from if you see in the right heart border, if the any chamber which is covering more than 50% of the right heart border, that means the RA is enlarged. Or if there is more than 15 mm from the center, that is the RA enlargement is there. So here the RA you can see, and here there is a straightening of the left heart border. The straightening of the left heart border happened in two reasons. There are three structure here. First come aorta, then pulmonary artery, then RVOT or LA, and then LV. So either there will be RVOT enlargement, so like in LA, like in this, or in the CHD, like in ASD or PAPVC, or when there is a very huge appendage, which is seen in more in rheumatic heart disease, that is known as the mogul or the elevation, then it's caused the straightening of the left heart border. So straightening of the left heart border is a two sign, whether it's because of the RVOT, here is seen in the dilated RA and the RVOT, which is seen in the ASD, and this is a typical triangular heart you will see in the ASD or in the dilated cardiomyopathy sometimes. Or so this is the one. So now okay. Now in the same way, if you see this, now see this. Now this is again the cardiomegaly is there, but the RV is is upturned. That means the apex is RV type. There's a huge RA. The vessels are very prominent, but you see in the periphery there are no vessels seen. So that means this is known as centralization phenomena, where the central vessels are prominent, but the peripheral vessels are very small. So this is the typical of again Eisenmenger prominent PA saturation. We again check it was 90% only with the ASD and the RV apex. That means it already crossed the stage of plethora and now turns out to be the Eisenmenger. So okay. Now sometimes the normal things also you see. This is the first day. You can see there is a round structure, the red. Sometimes what happened in the neonatal life, there's a ductal aneurysm will form because what happened, the duct closed from the PA end. So before the PA end duct close, the aorta is still filling. So that will give us shadow. Sometimes that will cause the bronchial compression. So once you see this shadow, that means in the neonatal age, that means there's a ductal bump is still there, it's not closed, and sometimes that if that large enough, it will cause the problem of bronchial compression. So you can see this is the ductal aneurysm in a one patient where is a connective tissue disorder and found to have the left bronchial constriction. And the when X-ray we saw, there is showing the round shadow. This usually seen in the first 7 to 10 days of the life. So once you see this, you are quite clear there is a ductal bump is there or ductal aneurysm is there. And if your clinical feature warrant, then you have to do the CT scan or the echo to prove that. Same, if you see the ASD, I showed the RA is dilated, RVOT is dilated, the LV there is in VSD, the plethora and all that. In the same way, what is the difference between VSD, ASD, and PDA? PDA, the flow will go more into the ascending aorta also. So that's why ascending aorta also become prominent. So you can see this is the ascending aorta feature. This is the ascending aorta. He is having the continuous murmur, and you can see the apex is LV type showing, and it's dipping down to the diaphragm. Although you will not see the LA enlargement very significantly, but this is a 12-year-old because of the more flow, your ascending aorta become prominent and your aorta become prominent. So these are the cases where you will see the all three VSD, ASD, and PDA, how it usually looks like. in any X-ray, first see the setting, second check the saturation, and then you have to see whether it's a plethora, no plethora, and then aorta or PA, whatever you see, you have to comment on that. So this is like that 2-3 patients for ASD, VSD, PDA. And now this another patient, this come to us when the child is having tachypnea and not diagnosed anything before. But when we see the clinical, you can see the upper limb, lower limb, there is a differential clubbing. So differential clubbing is a characteristic feature of PDA. Here you can see there is no cardiomegaly significant, but there is a RV apex and there is no vessel seen in the periphery. That is typical of the pruning. And the last thing you can see, there is a calcium arc like calcium seen. So calcium whenever seen in any patient, that suggests two things. The pH is significant. So presence of calcium is a pathognomic sign of idiopathic or any Eisenmenger pH. So here you can see the RV apex and then their differential clubbing. So that is typical of the PDA with the Eisenmenger and causing the calcium in the pulmonary artery. So these are the cases where in the right to left shunt, left to right shunt converted into right to left shunt. So these are anything anyone to comment, Madam Smita, Madam Munish, Madam anyone, anything?
No, this was very audience poll I did. Eisenmenger VSD and Eisenmenger ASD. So Yogeshri answered that actually in Eisenmenger ASD cardiomegaly persists or rather increased. And in the Eisenmenger VSD, heart size gets smaller and smaller over the period of time. That was a good, actually good answer. Another thing you have said and you have shown that ductal aneurysm and subsequently the calcium deposits. Very nice X-ray, and thank you so much for showing that.
Okay. So now we go from the left to right shunt to the obstructive lesions. Obstructive lesion, the general concept is whether it's a right or left, X-ray is very late. ECG is more suggestive of obstructive lesion until it becomes severe, where if the right-sided obstructive lesion until is associated with TR or RB dysfunction or very critical, then it won't show any X-ray features. In the same way, left side also it won't show any X-ray until it's very late. But this is suppose I'll show you. This is one 10-year-old with a long ejection systolic murmur, parasternal hue, and this is the X-ray. So the concept of the right side, what is happened, right side MPA normal is in more line with the LPA. So whatever jet is going, it mostly go towards the LPA. So that is the characteristic feature of the valvular pulmonary stenosis in full-blown valvular pulmonary stenosis, not in a neonate, where the LPA and MPA become more dilated as compared to RPA. That is known as preferential LPA prominence because of the streaming of the MPA, because normally MPA is more in the line with the LPA, sorry. So here is the patient, you can see the LPA and MPA are more prominent than the RPA. This sign is known as the Chen sign, where the preferential MPA flow will go, and that is suggestive of the pulmonary stenosis. In the same way, whether it's a mild, moderate, or AS, aortic, and the one thing very important, valvular stenosis will not correlate with the dilated. Suppose what I mean to say, mild PS can have severe MPA dilatation. In the same way, mild aortic stenosis have a significant aortic dilatation. The reason for both is not related to the wall, it related to the elastic, that means connective tissue disorder, that is on the cystic median necrosis of the MPA or on the aorta, that is causing the aortic and the MPA dilatation. So that is one of the very common question people ask, is severity of the MPA or aortic dilatation correlates with the semilunar wall intensity? No. Even the slightest of the stenosis may cause the very big MPA or aorta, or in the other way, severe MPA, severe pulmonary wall or aortic wall stenosis also will not cause any MPA or aortic dilatation. So here is a case of mild AS, bicuspid, known case of bicuspid aortic wall, follow with us. And when we show this X-ray, you can see the LV is dipping down, but the aortic shadow on the right side is very prominent. And on the same way, left side, you can see the ascending aorta shadow is very prominent. So here, this is known as the Shinu sign. Okay, so whenever this thing present, that is suggestive of the aortic stenosis. Severity we don't know. Severity, suppose if the pulmonary venous congestion, the cardiomegaly is there. So how to suggest severity in an obstructive lesion? Whenever cardiomegaly is there in an obstructive lesion, that means it's a severe. Whenever the vascular changes happen in the obstructive lesion, like if the critical pH oligemia you find out, that means it's a severe. In the same in aortic stenosis, you find the pulmonary venous cephalization or the Curly line or the minor fissure prominent, that means it's a severe. So obstructive.
So, Dr. Sudeep, one thing I would like to tell audience that in aortic stenosis, bicuspid aortic valve, always remember that aortic dilatation is one because of the that streaming of the high velocity blood flow, but also because the wall itself can be diseased and has a chance to get aneurysmal.
Yes, ma'am. That's what I told you. It's a connective tissue disorder. They found out there's a cystic medial necrosis, wall abnormalities there. That's why it's not correlated with the severity. Well pointed.
Yeah, exactly.
Okay. So suppose this is the aortic dilatation. What I mean to say on the right side. Okay. So what are the cases where you will get the aortic dilatation? This is very important. This is the ascending aorta dilatation, and this is the arch that is known as aortic knuckle. So how to get this into that? What are the features? What are the conditions where we will say the more aortic dilatation you will see? So the DD of aortic dilatation X-ray is this. Why? Because PDA and AP window more flow go to the aorta. So that's why the ascending aorta can be dilated. Top substrate, what happened? In the top substrate, apart from oligemia, other thing, aorta in more and more delayed presentation of the top. More flow go to the aorta, and this is and again connective tissue disorder in the aorta. It's causing the more dilatation. Aortic stenosis, I told, bicuspid aortic wall. Then apart from that, aorta to LV tunnel or aneurysm or aortopathy like in Turner. Like these are the causes. Whenever you find the ascending aorta dilatation in X-ray, these are the causes. One of the very important thing, ascending aorta dilatation, you will not see in the smaller age. Why? Because there is concept of aortic infolding. See, aorta is very sagittal in the infantile. As you become more older, it will come towards the more and more towards the right side. That is known as the unfolding of the aorta. That's the reason even in the large PDA, in an infant, you will not see the dilated aorta. But the same after 6 to 8 years, even in the moderate PDA, when the aorta, it will, because of the unfolding, it will come towards the right border. So that's what the aortic unfolding phenomena occur. And if you see the same in the adult, in the normal X-ray also, you will see the aortic dilatation. So that is the concept of the aortic infolding. The aorta is more centralized in the infantile age, and it will go towards more and more towards the right as the age increases. So that is the concept of the aortic unfolding. So again, this apart from that obstructive lesion, this is the one patient come to us 25-year-old with the hypertension. They referred to as hypertension. Nobody checked the radiofemoral pulses. How the clinical examination holds importance. So that is when they come to us, we found out there's the lower limb pulse is not there, and then we did the evaluation routine X-ray ECG. Here you can see very clearly, okay, there is a dilatation. This ascending aorta also is prominently seen here. You can see here ascending aorta, but there is a, you can see the rib notching is there. Okay, so and aortic knuckle. In coarctation of aorta, there is various coarctation. If you see the aortic knuckle is 90% abnormality. Whether you will see the rib notching is or not, that is imperative. Will not always see. You will see only after 5 to 6 years when there is a development of the collaterals. Then only. And now is very common thing. Even the normal infant, you will see the scallop like this. That may be normal. So how it's a different? If you see these are the, you can see the echogenicity. These are the very sclerotic zone. So once you see the echogenicity, that is more suggestive of coarctation notching than normal scallop of the rib in infantile. So because there is a compression, there is a vessel collateral which become probably because resorption of the bone and then the bone form, then it will cause the sclerosis. So that is the concept given why the sclerosis is seen with the coarctation but not with the scallops or not with even with the neurofibromatosis or the venous hypertension. So sclerosis is a very clear feature of the aortic site notching. Notching can be found. Why notching can be found in other lesions? I'll just 2-3 lines I will tell. Because of the lower border of the rib, three structure will go VAN, vein, artery, nerve. So all three will cause notching. Like in the SVC syndrome or SVC obstruction, you will get the venous notching. Second thing, artery. like then coarctation, get the artery. Third, neurofibromatosis, you will get the notching. Okay, so all three things will get notching. There is a very common question: why notching not happened in the initial first two ribs? So because first two ribs, the artery is not coming directly in the zone; it coming from the costocervical trunk or the intercostal artery. That's why it won't form the notching in the first two ribs. It don't go below 10th, 11th rib because it's an incomplete rib. So why it happened between 3 to 10 ribs? Because these are the collateral pathway. Because of the obstruction of the aorta, it will form and then it will form. And why it happened not in the anterior rib, only in the posterior? Because once the intercostal artery comes to the anterior, it will come to the center. It will go between the ribs, not at the lower border of the rib. So only in the 3rd to 10th rib, posterior portion of the ribs, only VA and bundle will be present. So that's why it's causing the notching in that area at that point. Okay, so this is the very important concept. They will ask so many times in the exam and in our clinical setting also. So this is the typical. You can see the X in an 8-year-old. You can see this is a 3 sign. Okay, sorry. This is the proximal portion and this is the stenosed area. If you see very clearly, so how to assess aorta on the X-ray? So aorta, I again tell this is the ascending aorta. You have to see always. I'll tell the other features also later. Always see the paraspinal region. You can see always paraspinal. There is the aortic shadow. That means the aorta is on the left side. If the same paraspinal shadow you will see on the right side, but the aorta is on the right side, and then you can see the tracheal indentation that we'll discuss later. But this is in coarctation. You can see the ascending aorta is prominent, proximal part is prominent, and then is the descending arc. So this is the typical of the 3 sign. What we call it the 3 sign in the aorta. So once
Excuse me, Dr. Sudeep, I just want to request our audience because it's a lunch time for many. So please, please make your video off. This is the lunch time and the lunch is going on. I think it must be distracting. So please make your video off and also mute yourself. Okay, continue, Dr. Sudeep. Hello, continue, Dr. Sudeep.
yes, obviously. So now this is the obstructive lesion, then large left to right. And now we come to the more important oligemia part. So these are the TOF variant and the TGA variant where the oligemia as well as the plethora is seen. So we'll go one by one with that. So in TOF, the general condition is the cyanosis deferred. That means the cyanosis present little later. Why this is little later? Because it's a progressive nature, presence of hemoglobin A, presence of PD. So usually their typical feature present after 6 months. Okay, murmur is inversely proportional to PA severity. That I don't know. There is usually no cardiomegaly. Why? This is very important concept. Whenever cardiomegaly when happens, suppose there is a obstructive lesions and then there is something to decompress because of the VSD, the pressure will never increase in the RV. It will get decompressed through the VSD and went to LV and then causes a right to left side. In the same talk with the obstruction, suppose VSD become restrictive, then you are become very big heart because the RV has to suffer, then the RV will fail over the period. So that is the important concept. No cardiomegaly usually present in the top. That is the question, and this is the usual things are. So what are the condition where the cardiomegaly present in the top, either the anemia, infectoendocarditis, or any wall regurgitation happen, or the VSD become restrictive, and because of the long standing, the hypoxia, the one muscle become itself weak, and on a hypoxic cardiomyopathy that will cause the exception. So typical top, you can see this is the X of the typical top. See, what are the things in the typical top? Why the boot shape happen? This is usually happen. Boot shape is not specific of the top. It present only in 50%. Boot shape is a normal phenomena in an infantile age. But what makes the boot shape specific in the heart in the top is this. This. Because there is no flow. So this portion, normally if you see the PA, there will be PA here. But the PA bay is concave. Once the PA bay is concave, that is suggestive the flow to the lungs is less and the PA are small. You see there is no vessel seen in the periphery. So that means there is a oligemia. You can see the RV apex is horizontal. That means it's towards the chest, not towards the diaphragm. So that means the RV apex is there. So these are the things which which makes the boot-shaped heart. So if somebody asks, what is the mechanism of the boot-shaped heart? So what happened in the top because of the clockwise rotation? The RV shift the LV up, so interventricular septum become more horizontal. This on X-ray will be reflected at the uplifted heart or the RV apex, and because of the RV apex, and there is a no flow to the pulmonary vein, pulmonary artery, so there is a constriction in the PA bay. So that is known as the concave PA bay. That makes the boot-shaped heart important in the top. Okay, so oh sorry. Sorry. Okay, so this, if you see, the narrow upper part is because of the small or absent MPA due to narrow infundibulum, which causes the concave PA segment. Toe upturned is approached because of the acute angle with diaphragm and because of the horizontal IVS causing clockwise rotation of the. So this is the complete answer why there is a specific boot shape present in the top. Okay, so sometimes the top is evolving. So suppose in 1 or 2 months old baby, when there is no severe stenosis, some vascularity is also present. So they behave more like, if you see the typical, this is a pink top where the RV is apex, where the vascularity is more as compared to typical top. So that is known as the pink top, where the is still not severe top developed, but it's on the process of developing the severe top. The vascularity is somehow maintained. So this is the maintained vascularity. This is the typical of the pink top. Now the third variant of the top is absent pulmonary wall. What is absent pulmonary wall? You can see there is no wall. So the flow will go, come up, go. So that's why causing the huge dilatation of the MPA and the RPA. So you can see, so that is typically known as the Mickey Mouse appearance. You can see the PA are very prominent. One of the very important point, only the proximal PA will be prominent here. So I'll take just here. See, only the proximal PA will be prominent. You can see the peripheral PAs are normal. So that is a typical of the top absent pulmonary wall, the huge RPA, huge LPA up to hilum. After hilum, it is normal. So that is a typical known as the Mickey Mouse appearance. What is more important in this is, once because of the PA dilatation, there is a more bronchial obstruction. So that is caused the more severe pattern of the disease. So top absent pulmonary wall, the prognosis depend on the compression of airway. Because of the large PA, it causes the compression of the airway and causing the more problem. Okay, so this I leave. Now, last stop is the VSD, where pulmonary atresia, there is no flow and there is no pulmonary artery support. So this is the typical. Now, I ask you, what are the other abnormalities present? So you can see these are the only vascularity present in the orange area, where otherwise there is no vascularity. That means the patchy. Somewhere vascularity is present, somewhere vascularity is not present. That means these are the collateral which is supplied. Boot shape we are seeing, but there is a presence of some deformity also, bone deformity. That is the hemivertebra. So whenever hemivertebra is present with the top, that is typical of the vectral. So this is the typical X-ray of a vectral anomaly where it's caused the boot-shaped heart as well as the top with the presence of the hemivertebra. Okay, so
And Sudeep, sorry, just go back. That rib. So on the right side, we can see that rib hemivertebra and then fusion.
the rib is not.
It's like very rare type of X-ray finding seen.
You can see the same right side, two ribs are also fused. So whenever hemivertebra are there, they are associated with the rib anomalies also. So this is the X-ray where you can see the this is a right, sorry, this is a boot shape, but boot shape is a but there is no vessels here, but only vessels in these area. These are known as patchy pattern. Whenever patchy pattern is, that means there is a vascularity, some other source of the blood supply go towards that. So that is just on the X-ray you can tell if some this X-ray come with a continuous murmur as well as a saturation of 80 or 85% desaturation, and then this X-ray you can typically tell this is a collateral supply to the lung as well as the presence of the hemivertebra. This is a typical of the veteran. Okay, so now one of the very important concept, what is pleonemia? So pleo means different, nemia means vascularity. So plethora means increased flow, oligemia means decreased flow, pleonemia differential flow. So like right side, These are the various patterns. Okay. So one I show in the first slide, you can see the right sided there is a vascularity pattern is in scimitar vein, but the left side is not seen. That is known as the localization. Lateralization I told, for example, only right side plethora is present, left side is not there. That means the RP is coming from the aorta causing right side plethora. Centralization, I told you, when the center is prominent but the peripheries are normal, like in Eisenmenger syndrome, where the center is very prominent but the peripheral pruning. Collateral, I told you, patchy distribution in some of the lobe, that is known as collateralization. Cephalization is the phenomenon in the pulmonary venous hypertension, where because of the more congenital lower lobe, there is a spasm and the pressure is low up, the veins will go up, and that is causing the cephalization, antler sign or mustache sign. Reticular pattern that I'll explain later. Reticular pattern is a tiny, that is suggestive of the interstitial lobar edema. That is again the feature of the pulmonary venous hypertension seen in typically in the TAPVC. Plethora means increased flow, oligomia means decreased flow, pleuropneumonia differential vascularity. So if you know this concept, then you'll able to know what is you're seeing on the X-ray. I won't go. This is this is one of the very ominous signs. This is complex heart disease. Whenever you find like that, see, normally in any X-ray, your right heart border should not be cut off. Once you see, see here, the right heart border is cut off. Means you are not seeing the right heart border. So what is the structure coming on the right heart is usually the RA. So that means RA is not there. So is it RA is not there? So RA shift to the right side, left side. So that is known as juxtaposed RA appendage, which is seen in the complex heart disease. Or this is also present in the chest deformity. Suppose a very pectus excavatum is there, that is pressing the chest, so it will cause the heart to shift on the left side. So you will not see the right heart border. So whenever any X-ray, if you see the right heart border is not there, that is always a very different sign. This is never normal. So chest deformity, pectus excavatum, scoliosis, that is one of the most common cause. Absent pericardium. What happens when the pericardium, the heart will move on the left side, right side, left side. So you will not see the right heart border. Or the RA is not there, it's on the opposite side, that is the complex heart border. So this I won't go. Now, if suppose this is the X-ray, what I told you, you have to always begin with the situs. You can see the stomach is on the right side, S is written, and there is a aorta. So whenever there is a situs heart discrepancy, so here the situs in inverse, the heart is on the left side, levocardia. So that is always associated with the complex heart disease. Okay, here the situs is not clear. We don't know, and the saturation is 80%, 70%. That also associated with the complex heart disease. One of the very common question with these two X, I will ask why the left diaphragm is lower or the right diaphragm is higher. So 90% of the people will comment because of the lever, the right side of the diaphragm become high. That is a wrong concept. It's not the right diaphragm which is higher. It is the left diaphragm which is lower because of the push effect of the heart. If you see here this X-ray, the heart is in the center. It's not either right or left. So that's why both diaphragm is on the same level. So this is in proves that it's not the lever which is pushing the diaphragm up, it's the heart which is pushing the diaphragm down. In the same way, you can see the heart here is on the left side, so left side diaphragm is higher than the right side. So these things, this is a very common question you have to take always that. So here, apart from that, you can see here when the stomach is not seen, you can see this is the liver shadow. Liver is seen here. Liver is seen right side, left side, both side liver is seen. And there is oligomia. So when such things are there, that is also suggestive of the very complex heart disease. And the oligomia is there. So important point, whenever situs as well as the heart discordances, that is always ruled out. Simple lesions will be ruled out. It always associated with the complex lesion. This is now one patient, we can see 7 days old, developed tachycardia in the cyanosis since birth. So this is the typical of egg on side. You can see this is known as the admixture lesion. Admixture means the all heart, all blood will come to the one chamber and then distributed everywhere. Here in TGA, there is incomplete or complete admixture will be there. Here, what happened? The aorta and PA will go anteroposterior, so you will not see the pedicle which is wide. Here it's a narrow pedicle you see. So that is like a string. And then because of the dilated RA, you will see this shadow. In TGA, I'll tell you, even one day the X-ray may change in 2 days like that. This is the first X-ray. seen on the third day, which was the normal, and now on the third day it becomes plethora and causing the egg on site appearance. So this is the typical of the TGA once you have to see the saturation at that point. So what is the causes for the narrow pedicle in TGA? It's a thymus. What happened? Whenever any cyanosis is there or stress is there, the thymus will get shrink. So because of the atrophied or absent thymus, these lesions are associated with the DJOG syndrome also, or anteroposterior great artery relationship with the hyperinflated lungs that will compress the narrow infant. These are the causes for the narrow pedicle in such X-rays. So now one thing you have to see what the side of the arch. So this is this X is particularly for this. This is known as the indentation side. So this is very important. That will be helpful for everything. You can see the trachea is there. Where the trachea indentation, the notch on the trachea. And second thing, see parallel to the vertebra. Here the vertebra, no shadow is seen. But you also see the slight shadow is seen. So this is the shadow of descending aorta and the arch. So what is the definition of the arch-sidedness? So whichever trachea side arch is indenting, and I'll show the examples in the next slide. So see, this is the normal. You can see this is the normal trachea. Okay, the arch, this is a normal trachea. The indentation is on the left side, so this is the left arch. This is the indentation is on the right side. That means it's a right arch. Sometimes it's a center, but you can see the slight indentation on the right side. So this is on the right arch. So you have to combine this indentation sign uh, with your aortic shadow on the in the paravertebral region. So this is the aortic shadow on the paravertebral region. Sorry, aortic on the paravertebral, that is show the descending aorta is on the left side. Here the indentation right side. That means the right arch with the right descent. So with that, sometimes some X-ray you can able to diagnose the complex heart disease. Right arch with the left descent. That means the circumflex arch. Right arch with the right descent. That means the right arch is present. So you can comment on such, because why this is important. Right arch is present in so many of the congenital heart disease. TOF 25 to 37 of the percent of the TOF have right arch. If the complexity of TOF increases, arch sightedness also increases. If the D-George association of the increases, the right-sided arch sightedness will increase. So that's why in the TOF absent pulmonary, 50% of the patient have right arch. VSD pulmonary atresia, severest form of the TOF, it is 60 to 70%. But the most common heart disease which is associated with the right arch is the truncus and the interrupted aortic. Okay. So now this is a one patient with the cyanosis comes to us with the palpitation. It's a huge heart. You can see the heart CT ratio. If you see, I see the CT ratio is almost filling the 90% of the chest. So this is known as a huge cardiomegaly, and this is also known as a wall-to-wall heart. But the oligemia is there. If the oligemia is there, that means the RVOT is there. So once the oligemia is there, that is typical of the critical PS or Epstein associated with that. So this is also known as the box-shaped heart or pumpkin heart, and this is typical of the Epstein's. This is if you see this in a neonate, you can see the what I tell the CT ratio is nearing 100%. So whenever CT ratio is nearing 100%, there are only 2-3 diagnoses. What the multivalvular involvement in the RST, like TR, AR, MR, all is present. Or in a neonate, always is right-sided pathology like critical PS, severe TR, or Epstein's anomaly, pulmonary atresia, intact IVS, or tumor, or there is a large pericardial collection. So this is the term where the CT ratio almost reached the 100% of the known as wall-to-wall out. So neonatal Epstein's tumor or thymus sometime will mimic that. Sometime I told you aorta will see on the left side, but aorta you can see the aortic shadow is imparting very huge shadow, very long. So this is always abnormal because aorta always impart only small shadow. Once it imparting the large shadow, that is typical of the CCTGA, or you call it as L Malpos aorta. Okay, now this is the first case. This child comes with a severe PH. We're not able to find out the cause. So once we saw the old X-ray, you find out this. So this is the typical. You can see there is a one shadow scene which is going towards the IVC. So this is the typical of the scimitar syndrome. Here the cause is scimitar syndrome, which is causing the severe PH. This is 5-year-old diagnosed to have. Now came but the saturation 90%. You can see what is typical of this. They miss during early pregnancy, but this is typical of the figure of 8 appearance. Remember, figure of 8 appearance comes only after 6 months. Before that, the veins are not that dilated to cause that. Okay, so this is the figure of 8 appearance, but again in the same way, if you see this also showing figure of 8, but the saturation is normal, clinical examination normal. So thymus can mimic anything. So this is the large thymus which mimic the figure of 8 appearance. So this again, this will leave. This again, what are the different signs? Because thymus can masquerade anything. So this is the typical sale sign where you can see. But what is the most important sign? Because thymus is not inside the heart, it's outside. So it will never blend with the heart. It will always see a notching sign here. You can see, a notch sign. So whenever notch sign is there in a gross cardiology, that means it's a thymus. Second thing, it's like a sail here, and it's a wave sign. It's atypical. So that is typical of the thymus here. So thymus can form any shadow. So what are the different sign of the thymus? So you can see this is a typical sail sign of the thymus. Okay, this is the typical notch sign, ripple or wave sign, because the thymus is indulating, it is indenting on the rib, so it will cause the wave sign because of the indentation of the thymus on the rib. Okay, so these are the various signs: sail sign, notch sign, curtain, wave, or indentation sign. These are the various signs which the thymus will be. This is very good X-ray. You can see this child developed the air leak syndrome. So whenever the air leak syndrome, and you will see the thymus uplifted, that means the air is in the mediastinum. So that is very important feature. That is known as the angel wing sign. This you can see here. This is the thymus. You can see. This is, sorry, I'll just first remove it. So this is the thymus you can see. So that means thymus is seen because pneumopericardium never go into above the heart. But if the any air which is going above the heart and causing the thymus to uplift, you can see in the lateral X-ray also, that means there is a pneumomediastinum. So that is the typical X-ray of the pneumomediastinum, which is known as angel wing sign, and that is known as the Spinnaker sign. Now this is one X-ray. There is no distress. How the clinical examination have no distress, but the saturation is 88%. So no distress. Child is comfortably coming, but it referred as a pneumonia. If you think that much pneumonia patch is there, will the child be not symptomatic? Definitely some fever, something will be there. So once you see like this, so what you have to see, this is the large shadow. Okay, so this is a large shadow. So sometimes the pulmonary AVM can present like that. So this is the typical. So what is the here the clinical clue? There is no symptoms. Child is comfortable with severe cyanosis, and there's a large round shadow. You can see with the angiogram, there is a vascular pedicle also seen. That is a typical of the X-ray of the pulmonary AVM. In the same way, sometimes this also cyanosis. We are unable to know the cause of cyanosis, but once we know retrospectively, you can see here the hilum is very hilum will be always like this clear. But if you see the hilar shadow is there, so that is the typical. Sometimes RPA to LF is a form of the pulmonary AVM that is causing the problem. So you have to see the hilum, you have to see the above the clavicle, below the heart. And this is my favorite 23 years old single ventricle PS physiology with ankle joint tenderness. So what we call it, why ankle joint tenderness? So this is the typical what we usually mark, a type 4 clubbing hypertrophic osteodystrophy, where there is a, you can see the periosteum is irregular. That is known as hypertrophic osteoarthropathy. This type 4 clubbing, which is because of the periosteatis, continuous hypoxia in a cyanotic heart, and it's causing the periosteatis. It's the last case because this patient what having come to the chest pain is an 8-year-old, but we're not able to find out the cause of the chest pain. And when we saw the CT, we always missed. But when we saw the X-ray again, I told you the right heart border is absent, and these are the Snoopy appearance and the dewdrop appearance. So that is typical of the absent pericardium. This chest pain is because of the absent pericardium. So even you see the X-ray can give you so many clues over that. This is also, you can see normally the rib is always, just 1 minute, rib is always like this, curved. But when the rib becomes straight like this, that is known as 7 reverse 7 sign. So that is typical of the pectus. If you see the lateral X-ray, you come to know it's a sign of the pectus, and this is referred to as for the cardiomegaly and the murmur. Because of the pectus, there is a murmur compression of the aortic causing the systolic murmur. And here also you can see the right heart border is not seen. So again, with that commotion, with the same criteria, the right heart border absent, there is a chest deformity and there is a 7 sign. And this is the RSD patient. They come with the severe distress. Identify the structure. What happened? This is the sign known as the vanishing tumor or the phantom tumor. This is because of the increased pulmonary venous congestion. Once you give the Lasix ventilation and improve the left heart function, this will disappear. That's why this is a tumor because of the minor fissure edema, because of the pulmonary venous hypertension, that is known as the phantom tumor. So, in general, whenever you find the increased vascularity, when the cardiomegaly is present and the MPA shadow is seen, when there is more flow, that is related to ASD. If it is a right heart enlargement, ASD, TAPVC. If it's a left-sided enlargement, it's a VSD, PDA. And with the aorta enlargement present, it's more suggestive of PDA than VSD. Cardiomegaly is present, irrespective of sinus. MP shadow is not seen. That means that TGA truncus or CCTGA, that means the MPA aorta posterior is there, you're not able to see the pulmonary artery shadow. So these are the, in general, increased pulmonary vascularity. What happened? Only with the shunt ratio of 2:1, you will find the cardiomegaly. Only with the shunt ratio of 1.5, moderate shunt, you will find the vascularity increase. In the same way, if you see the decreased vascularity, oligemia, cardiomegaly is present. That means it's a Epstein's, PS, organic. If the PA is also, MP is also prominent, that means it's a PS is associated. No MP prominent, that means decreased flow, that means it's a Epstein's. Or when the LV apex is there, that means the tricuspid atresia is there. In the same way, top physiology with no cardiomegaly, LV apex is suggestive of tricuspid atresia, while in RV apex is of the severe typical top. In the normal vascularity, MPA prominent, obstructive lesions are more prominent, PS, aorta prominent, more ascending AS or coarctation, right heart dilated PR or cardiomyopathy, or left heart it's the MR lesion. Okay, so thank you. Just sorry, 1 minute. If you give me 1 minute, I'll show what I want to forgot here. Till the time, madam, you want to comment anything? I just take 1 minute of your.
It's a great presentation, I think, and you have made X-ray reading so easy. So, any question from audience, if you want to ask, apart from they want to have this presentation subsequently. So that is also a question. We do share recording of all lectures. Yeah. So, so this is what it is. And the second thing is about the AV fistula, pulmonary AV fistula. It's very nicely shown that the patient remains asymptomatic and you get a kind of sometime pneumonia kind of thing or aneurysm kind of presentation on the X-ray. But these patients may have quite a good cyanosis. So SpO2 probe remains a very good ally whenever you are trying to read an X-ray. Probably you should also warm the limb and have a SpO2 reading. So it makes a lot of things easy.
Just last comment, madam, I just want to show the apex. I forgot to show it separately. Is the base to apex axis is directed towards this, and towards axis is down and towards the leftwards, and the cardiophrenic angle is obtuse. This is the usual of the LV apex. The cardiac border, diaphragm border, sagging apex merging with the diaphragm. That is the typical of the your LV apex. In the same way, if you see the cardiac axis like this, cardiac. So that is acute angle forming. That is the typical of the RV apex. Okay. That's all. Thank you.
So Dr. Vinny Saxena is there. Sir, would like some comment from your side. Thank you for joining, sir.
Yeah, it was a really very wonderful presentation by Dr. Sudeep, and especially correlating physiology with and clinical science with X-ray. And of course, it is his own collectively useful for every pediatrician. A wonderful presentation, Sudeep.
Thank you, sir.
So, thank you, Sudeep. And Dr. Smita, from your side, just closing comments.
Okay, I am quite a great lover of reading X-ray, and as situs abnormality, it is very well shown that actually liver hates heart kind of thing. Because if you have a liver and a heart apex on one side, you should know there might be twisting at the level of atrioventricular segment, and the connection may be abnormal and may be a grossly, very, very grossly abnormal, very complex disease. So that is also a very important information Dr. Sudeep has given. So I think the very nice summary slides actually at the end of presentation. I appreciate all of them. Neonatal, you said the neonatal cardiomegaly, very important thing, pulmonary, absent pulmonary valve of pulmonary atresia, tricuspid regurgitation. So cardiomegaly always says somewhere is regurgitating. I think Sudeep will agree. Except that if it is not a supraventricular tachycardia and cardiac failure is there in newborn or in
And
fetal.
cardiomegaly is a sign where you have to see fetal CCF also continues in
Yeah,
neonatal, and
yeah.
you have to continue sepsis, all other things. So that's why there is a saying by our great teachers, it's not the only thing. It's like you have to combine everything for the benefit of the patient. You should
Right.
take clue from the X-ray, ECG, and must clinical scenario is must, because so many of the patients they are not seeing. Yesterday, one referred totally normal, it was a huge thymus. They are not able to tell about the thymus sign also. So first, until unless we know okay, these are the things, we'll not able to justify our clinical scenario also. And
And the other thing is, yeah.
sometimes we overestimated also, but it's overestimated not to miss anything than to underestimate or under. So that's what if you think there is a heart problem, not turn out to be it's good. But if there is there and you miss, that is the worst thing for the patient. So that's why it's always the combination approach of your clinical X-ray, ECG, then echo, everything is also coming into that. Thank you.
So that is very important question was like the LA enlargement in the rheumatic heart disease and LA enlargement in the left to right shunt. So I would like to add that in LA enlargement in the rheumatic heart disease mostly have pulmonary venous hypertension, and in the LA enlargement in left to right shunt, most of the time you get a increased pulmonary vascular marking because arterial dilatation and arteriolar dilatation and vascular markings are very, very high, as Dr. Sudeep shown us on the all post-tricuspid shunt. So that is a difference which I asked like in the start and that I am giving the answer. Okay.
And
Thank
plus,
you.
L-appendage is important. That is for the rheumatic disease.
Rheumatic, yeah. Yes, yes.
Actually, I made a mistake. I should combine the all chamber enlargement also. Actually, I forgot that. Sorry
You
for that.
did make a single mistake. हमें तो ढूंढना पड़ रहा है कि कुछ हम बता सकें. But you have covered everything so beautifully.
I think I should add RALA enlargement, all those things also. I have to add one. Sorry.
So patient in totality, clinical, X-ray, ECG, saturation is so important, and X-ray in totality, not on the heart, not only the lungs, not like everything is important. Like Sudeep said, perimetry is important, and then approach is your choice. You can go from inside to outside or outside to inside, up, down, or but you have to look everything in totality. So you get so many things like hemivertebra, that rib issue, absent rib, cervical